I'm going to be discussing high-intensity resistance exercise as compared against traditional therapeutic exercise in regard to improvements in hand function in subjects suffering from rheumatoid arthritis. It has been believed in the past that high-intensity resistance exercise would promote joint degeneration and deformities, and therefore therapies often focused on submaximal exercise designed primarily to increase body awareness and maintain joint function. Rheumatoid arthritis itself is an autoimmune disease in which the body's immune system attacks the joints, and these joints are just regions where motion is created in the body, and all of the joints are protected by cartilage, which can degenerate due to the autoimmune attack, and they are also surrounded by a fluid-filled sac called bursa, which can become inflamed due to the autoimmune attack and create a lot of stiffness and pain. Now, muscles surrounding the joints provide stability, and exercise actually initiates a metabolic response which can promote healing in the muscles and the joints around them. But exercise can also initiate inflammatory responses that can cause wear and tear on the joints and could possibly exacerbate symptoms that would be seen in rheumatoid arthritis. Now, when we define exercise intensity, we're going to be defining that in relation to a percentage of maximal capacity, and often in research they'll use it as a rating of perceived exertion, where a 1 will be almost no effort and a 10 will be maximal effort, for example. Now, in the following research, none of it is actually done on subjects who have major joint deformities, which is important because the exercise may not function in the same way in people who have active major joint deformities as it does in people who simply have early stage or moderate rheumatoid arthritis. The first study that we're going to look at is a 2009 study conducted by Sophie Bjornsson, and it is titled "A 6-Week Hand Exercise Program Improves Strength and Hand Function in Patients with Rheumatoid Arthritis." So in this research, the goal was primarily to investigate how strength and hand function would improve differently across two groups: subjects with rheumatoid arthritis and a healthy control. And the primary measure in this case included the amount of force able to be generated in finger flexion and extension. So 20 female subjects with rheumatoid arthritis were recruited from a hospital over a 1-month period, and 20 age-matched healthy female control subjects were randomly recruited. Specialized devices were initially used to measure the finger flexion force, so the closing of the hand, and the finger extension force, which is the opening of the fingers. And subjective levels of pain were also measured before and after. Other measures included the grip ability test, which is just a series of everyday tasks designed to assess how the rheumatoid hand would function in everyday life. Muscle quality of the extensor digitorum was also measured, and this is just the muscle that runs along the top of the hand and helps to extend the fingers. And this was just done by thickness, contractile efficiency, and the area of the muscle fiber. Prescribed exercises were performed against resistance putty 5 days per week, with 10 reps per exercise, and on each exercise, maximal exertion was held for 3 to 5 seconds per rep, with 20 seconds of rest between repetitions. So this would have utilized a maximal exertion. The study was done for a total of 12 weeks, with measurements taken at 1, 6, and 12 weeks. So the ultimate results at the end of the study showed that finger extension force increased by 36% in the subjects with rheumatoid arthritis versus 25% in the healthy control. Finger flexion force increased by 40% in subjects with rheumatoid arthritis versus 14% in the healthy control. Muscle size of the extensor digitorum increased on average in only the rheumatoid arthritis group, but this was simply brought up to match the muscle thickness in the healthy control. So some of the limitations of this study include the fact that the device used to measure the finger extension force was shown to be reliable in healthy subjects, but it was not researched for reliability in the rheumatoid hand. The sample size was small, so it's difficult to draw large generalizations from this research, and disease duration among the rheumatoid arthritis patients varied significantly, so that could have impacted some of the results as well. Limitations. The next study that we're going to look at was conducted by Zide Zhang in 2004, and it's titled Long-Term High-Intensity Exercise and Damage of Small Joints in Rheumatoid Arthritis. And the goal of this research was to look at the effects of the exercise on both the rate and the number of joints damaged in the small joints of the hands and feet in subjects with rheumatoid arthritis. In this case, data was analyzed from a separate large-scale study that was conducted over a 2-year period. 136 patients with rheumatoid arthritis participated in a supervised biweekly high-intensity exercise program, and 145 patients with rheumatoid arthritis were placed into a usual care group, which included joint splinting and joint protection education. These subjects agreed to refrain from high-intensity resistance exercise over the 2-year period. An attending physician was assigned to treat both groups, and they had control over medication and any other treatment strategies. Joint damage was measured by joint space narrowing, as well as erosion of the joint on a scale of 0 to 200, and any other factors that would have affected this were attempted to be controlled for in the statistical analysis. The results showed that an increase in the rate of joint damage was significantly lower in subjects participating in the high-intensity exercise, but the increase in the total number of joints damaged was similar across both groups. So there were some other factors that were associated with increasing joint damage, and this included lower improvements in muscular strength, a faster rate of bone density loss, higher joint damage at the outset, and higher disease activity. So the joint damage at the outset and the disease activity would not be affected by exercise, but we know that increases in muscular strength and bone density are associated with exercise, so this would lower the rate of joint damage. Some limitations of this research include the fact that the number of participants was based on the ability to detect clinically relevant changes in the health assessment questionnaire, and it was not intended to detect clinically relevant changes in the rate or number of joint erosions. It did reach statistical significance, but it may not have reached clinical relevance, so this may not change how physicians actually interact with the subjects with rheumatoid arthritis. And across both groups, differences in disease activity and duration were significantly different despite randomization. The final study that we're going to look at was conducted by Sarah Lamb in 2015, and it's titled Exercises to Improve Function of the Rheumatoid Hand, a randomized controlled trial. And it simply analyzed the effects of a tailored strength, flexibility, and endurance training program on the hand function subscale of the Michigan Hand Outcome Questionnaire, which has shown to be reliable in measuring the overall health of the rheumatoid hand. Subjects were randomly recruited by telephone from any one of 17 hospitals designed to deliver secondary health services in England, and 244 patients were put into the usual care group, which included joint protection, education, and functional splinting, and 246 patients were put into the exercise group, which included 7 mobility and 4 strength endurance exercises with resistance provided by bands, balls, or therapeutic putty. Perceived exertion was set to be moderate to somewhat hard, and subjects were told to systematically increase the amount of repetitions that they did at a given resistance, and then to increase the resistance, so standard strength training protocol. Follow-up data was taken at 4 and 12 months, and the results showed that the exercise group improved its score on the hand function subscale by nearly twice as much as the usual care group, and that those improvements were seen across the entire Michigan Hand Outcome Questionnaire, being nearly 2 times or 2 times greater than the usual care group. And at 12 months, 45% of the exercise group patients reported overall improvements versus 21% in the usual care group. Now, some of the limitations included that the sample size was not necessarily large enough to account for drug regimen or disease duration. The fact that data protection law does not allow information on those who declined to be in the subject or in the research, so selection bias can't be ruled out. So conclusions that we can draw from looking at this research are, for one, it's clear that high-intensity resistance exercise is not only safe when overseen or prescribed by a physician, but that it's likely to actually improve functional outcomes for subjects with rheumatoid arthritis. It's important that we could establish that there was a decrease in the rate of joint erosion, because this supports the long-term efficacy of high-intensity exercise, due to the fact that simply degeneration of the joints obviously decreases the functional ability of the hand in the long term. It may be the case that a lack of exercise more than rheumatoid arthritis specifically contributes to joint weakness, and this is just evidenced by the hypertrophy of the extensor digitorum that was brought up to match the healthy control in the research that looked at muscle quality. All the exercises in this case were overseen or prescribed by a professional, so it's unclear what improperly performed exercise or improperly prescribed exercise would do to the rheumatoid hand. It is important that a professional oversee this. The risks of atrophy due to a sedentary lifestyle should be made clear to patients, and people are more likely to be sedentary if they are in pain, so it would be especially important to stress this to subjects with rheumatoid arthritis. The low cost of exercise interventions when compared against medication or specialized devices should also increase the appeal, as it can very easily be added to other forms of treatment.